So welcome everyone to today's Hypertension Getting It Right webinar that's part of our long-term condition webinar series. You'll see on the screen that there's one on COPD and one on heart failure coming up as well. I am a Camden GP and I chair the NCL Training Hub and Camden Training Hub, and we're really pleased to, as part of what we do, to offer these long-term condition webinars. They're also recorded, and so people who are unable to join us, and we know from the number of people accessing the recordings that it's very popular for people who can't get here on the day but who do still want to be able to benefit from them. So I'm going to hand over to Liz and Joe to introduce themselves and thank them very much for being with us today to do this webinar. If you've got any questions, please do put it in the chat. Also, if you want the slides, you need to put your email address in the chat, and also feel free to put your hand up at any time. Thanks.
Hi, can we have the first slide, please? So my name is Elizabeth Denver, or known as Liz Denver, and I've been a hypertension specialist nurse at the Whittington since 2000 when we set up the clinic. I primarily see people with diabetes, type 1 and type 2, but I also see a lot of patients from the nephrology team. And I'm a member of the British and Irish Hypertension Society Blood Pressure Working Party, and we are the ones who check any validation of new blood pressure machines and decide whether or not they will go on the BIHS website as recommended machines. And I had the pleasure last year of being on the NICE guidelines committee that reviewed hypertension in adults. Next slide. So you've got some excellent information that Sarah sent to myself and Joe, and what I've done is I've just pulled out some bits of it. I mean, some of the slides were very busy, so I've taken just a section of them. So stage 1 hypertension we class as if the clinic blood pressure is between 140/90 and 159/99, and the ambulatory blood pressure daytime average or home blood pressure is 135 to 1/85. So that's going to be probably quite a lot of your population who are in the lower end of hypertension. Stage 2 is 160/100. I'm not going to read it all the way through. You can read it yourselves. Stage 3 is 180 or above, or diastolic of 120 or above. Next slide. We also have accelerated or malignant hypertension. This is often changes its names to other things as well, but this is what we agreed was the name of it when we did the NICE guidelines, accelerated or malignant hypertension. And with that, the blood pressure is above 180 or 120, plus there are signs of retinal hemorrhage or papilledema. That is when you refer a patient to the emergency department. If somebody has a blood pressure of over 180, you don't automatically need to refer them to secondary care, but we do recommend that you review their medication and recheck their blood pressure in a few days if at all possible, or if they're doing home readings, get them to recheck it. Next slide. So we're going to quickly go through blood pressure measurement, and the reason for this is, unfortunately, healthcare professionals are not always very good at measuring blood pressure. And sometimes when I've had my blood pressure being measured, I've had to stop the person and ask them to do it correctly. And I have observed some practice which is not good. And if we are going to look after people's blood pressure, we do need to measure it accurately in the first place. Otherwise, we're going to end up with erroneous results. So we do recommend that if it's a new patient, you measure their blood pressure on both arms if at all possible. There are going to be exceptions where you can't do that. And if there's a difference of 15 millimeters of mercury, then you recheck the blood pressure. So you would do your readings on the first arm, whichever, it doesn't matter, left or right. Do the 3 readings, as I'm going to go through in a minute, and then do one on the other arm. And if there is a significant difference, then recheck it again. If the significant difference is there, you should inform whoever has asked you to measure the blood pressure. And you should also continue to measure the blood pressure always on the arm with the higher reading. And I did have a patient a few years ago who on their left arm, their blood pressure was in the 180s, and in their right arm, it was in the 120s, which made a very significant difference to their treatment. And when I inquired at that time about what we should be doing for this person, I was told quite clearly by the experts, because I was fairly new to the job then, we should be aiming to get the blood pressure that's high down to the better reading. So I hope that all makes sense. Obviously, if a patient has had a stroke and an arm has been affected, you shouldn't measure the blood pressure on that arm. Next. So, how do you measure a blood pressure? Well, the first thing is to ask the patient to have a seat. If they've got a jumper or a coat or some kind of tight sleeve top on, ask them to either take that, slip their arm out, or they may need to take the whole top off. Don't try and measure blood pressure over people's clothes. You won't get an accurate recording. They should also sit with their back supported. So that means that if you can't really see me, but if they're sitting in a chair, their back should be against the back of the chair. They should not be leaning forward like this, which is what most people do because they're eager to help you. They need to sit back, legs on the floor, no legs crossed. Make sure you've got the right size cuff. Make sure that the cuff is the right way up and the right thing is over the artery, over the brachial pulse. And get them to just sit for a few minutes. You can discuss whatever you need to discuss while they're sitting there relaxing. The other thing that's really important is that their arm is supported and is straight from the elbow to the wrist. And the reason for this is it can actually make a significant difference to the blood pressure recording. If the arm is not supported, you will get a false high reading. And if the arm is held above the heart, so up in the air like this, you will get a false low reading. Even if you're supporting it, if it's held up like this, you will get a false low reading. It needs to be straight from the elbow to the wrist and supported. And nobody should be talking. I saw an advert, an article one day in Nursing Times a few years ago, and it said such and such a staff nurse talks to the patient while measuring their blood pressure, and I had to write in and say no, they don't. Nobody talks while you're measuring the blood pressure. Now, to some extent, it doesn't really matter which blood pressure machine you use. We do recommend certain blood pressure machines in BIHS, but if you use a really good machine and you don't use it properly, you'll still get incorrect results. There is one exception. If somebody has an irregular pulse, you shouldn't use an automated device if at all possible, because they are not designed to measure blood pressure accurately. Some machines will advise you if the pulse is irregular or the heart rhythm is irregular. Some will claim to measure blood pressure in atrial fibrillation, but we have checked them and checked them and checked them on the BIHS, and they are not accurate. So if you don't have access to a manual machine, which is the best way to do it, and you have to use an automated device because you're out in the community and you're going around people's homes and you can't be carting around 6 or 7 different blood pressure machines, then what you need to do is do at least 5 measurements really and take an average if at all possible, but certainly no less than 3, because you will find that there is variation in the blood pressure results that you get. Next slide, please. Always do at least 2 readings. I've put 2 minutes apart, but it's actually 1 to 2 minutes. It's fine. So you do the first one, wait a minute or 2, do the second reading. If the second one is significantly different to the first, then wait another minute and do a third. I have had some patients who are so tense when they come to clinic that I've ended up doing about 5. And what's happened is the blood pressure has started up here and it's just gone down and down and down and down and down as they've calmed down. Now, white coat effect, white coat hypertension effect can be a problem, and it is something we recognise that should not be ignored. However, if somebody really does have a fairly calm, good resting blood pressure, when they've stopped being anxious, we need to be careful about increasing their medication, because what might happen is once they start taking more tablets, they then drop their blood pressure too low once they're away from the hospital or the clinic, and they end up falling over and getting side effects. So an accurate blood pressure recording is really important. If you know the person has come to you with a history of falls or chronic kidney disease, then it's best to do a sitting, do the 3 sitting or 2 sitting, and then get them to stand up and do a standing blood pressure. If the standing blood pressure has dropped, then you repeat it after they've stood for a minute, and if possible, you repeat it after 3 minutes. If it's really bad postural hypertension, you may find that you can't even keep them standing up for 3 minutes. And again, I've had that happen, where the person was getting so dizzy they had to sit down fairly quickly, and then you need to review your medication. Next slide, please. Sorry. So as I said, why does accurate blood pressure measurement matter? Well, here's an example of a patient I saw not that long ago. Initially, their blood pressure was 142/64, and after a minute it dropped to 132, and after another minute to 123. Now, 123/63 is a perfectly acceptable blood pressure. I was not about to start changing their medication. If I'd gone by the 142/64, they had chronic kidney disease, the systolic would have been regarded too high for our targets, and I may have started changing their medication. So good blood pressure measurement really is the basis for treating patients. Next slide. These are the blood pressure targets that were set by NICE last year. So the non-diabetic patient under 80 years of age, the target is less than 140/90. If they're over 80, it's less than 150/90. The reason being that people over 80 often have more adverse events, side effects from medication, and there isn't the evidence to support having a lower blood pressure target. If they have type 2 diabetes, then we changed the target to less than 140/90. It had been 130/80. However, if those patients also have chronic kidney disease and other comorbidities, then we would keep the target at 130/80. So most of our patients with CKD will also have a target of 130/80. And at the moment, the target for type 1 diabetes has stayed at less than 130/80. That did not change, and that is being reviewed by another group. Next. Jo.
Thanks, Liz. Welcome everybody, and thanks for joining us today. My name's Jo Henry. I'm the Community Hypertension Nurse and CKD Lead with Camden and also NCL as well. So when you're checking blood pressure at home, when I run my community clinics, I'm teaching patients how to be able to monitor their own blood pressure at home as well. And I like to use like a flyer like this just to act as an aid memoir to help the patient then when they're doing it themselves at home. So, for example, we'll do advise them to don't smoke, no exercise, no drinking caffeinated beverages or alcohol 30 minutes before you take the reading. You might need to empty your bladder first, and then you're sitting with both feet flat on the ground and your back and arms supported. And of course, it's important that we're using a validated machine, an upper arm machine preferably, and that the cuff is fitting the top half of your arm properly. You're sitting in a relaxed position and you're placing the cuff on your bare skin or over very thin fabric. The cuff should be at heart level and the arm resting comfortably on a flat surface. And you're sitting quietly for 5 minutes before you take the reading, and to be silent and don't talk during the reading. Both the well, obviously this is somebody who's doing it at home, so we don't want them to be talking during the reading. And then what we want them to do is each time they take their blood pressure, that they take 3 measurements, and they separate it by 1 to 2 minutes each reading, and they write the results down as well. So it's just to sort of point out this is kind of like a handy flyer. Next slide, please. So when we're doing home blood pressure readings and advising people as well, just to remember that the home blood pressure reading and the targets we're looking for, they should be 5 millimeters of mercury lower than those set in the clinic. And it's important for patients as well to know what their target is, like what reading is it that they are looking for, and to write down all the numbers as they appear on the screen. A lot of the time I'll give my patients the blood pressure diary sheets that are on the British and Irish Hypertension Society. And then what we'll do is when I see them again, we're able to discuss all of those readings together, and also to write down anything that might have affected the readings. So, for example, it may be that we've changed medication, and actually it's a good point for us then to be able to observe what effect did that change in medication have on the readings, or if it was a day they were feeling unwell, or if they had dizzy spells with particularly low readings, etc. as well. Next slide, please. So just to go back, like this is Liz's slide again, and it really is to reiterate the point that actually taking an accurate blood pressure really is important, because it really does affect what we do. So therefore, teaching the correct technique is really important. And actually, we'll find as well that with patients that they appreciate that as well. And even things like at home, like with white coat hypertension, it may be just that actually this is where the home readings really are so valuable for us as a tool to help us what's our next step going to be here in helping them achieve a controlled blood pressure. And also the other thing is that there can be so many different targets and blood pressure targets that's what's confusing for people. And you can be looking after people that within the one household that actually there's somebody who's over 80, so their target is 150/90, but a home reading is 145/85, and there's someone else in that household who's an adult with diabetes, chronic kidney disease, their target is 130/80, and someone else who doesn't, and their target is 140/90. So I think a lot of the time it's important here that we just make sure that we're telling people what target it is we're looking for. Next slide, please. So again, looking at what is the target, and then obviously advising them, because they're measuring their blood pressure at home. What we want to know as well is how, when do we want them to submit those readings, and how to submit those readings as well, particularly for our own records as well with EMA, so that we can have accurate and up to date. There's so many people out there that have hypertension that actually we haven't had a chance to get a recent blood pressure on them. So it's important, and also helping safety net them as well, so they know when to seek help with according to their readings, and when to highlight it to us as well. And just to say, people that are uncontrolled, really they require more monitoring and control as well. Next slide, please. So I'm going to hand back to Liz again.
So next slide, please. So this is the algorithm from the NICE guidelines from 2019. All diabetics and non-diabetics under the age of 55 should be started on an ACE inhibitor or an ARB. That's the ones that end in sartan, such as irbesartan, losartan, valsartan, etc., which is slightly different to previously. It was ACE or ACE inhibitor on its own, but the ARBs are, I think, off patent now, so they're pretty much the same price. And unless there's a contraindication, that might be excuse me, that they've got a very high potassium level for some reason, in which case you might have to use caution. But the non-diabetic patient, aged 55 or over, or a black patient of any age who's non-diabetic, not diabetic, you would start them on a calcium channel blocker. And then the next step, if that doesn't control the blood pressure, would be to add in the one you hadn't given or a thiazide type diuretic. Now, I'm not sure what the Camden formulary is these days. When I looked a year or two ago, I think it wasn't a thiazide type diuretic, it was actually bendroflumethiazide, which is a thiazide diuretic, and we don't actually recommend that as the second step treatment. We recommend indapamide, which is basically the only one you can get in this country, generally speaking. Chlortalidone is the other thiazide type diuretic, but it's extremely rare to come across it. So you would give somebody an ACE plus a calcium channel blocker, or an ACE plus a thiazide type diuretic, or if they're on the calcium channel blocker, the other two. And if that doesn't work, you then give them all three, assuming they're going to take them. And if that still doesn't work, then if they've got a blood potassium that's 4.5 or lower, you could add in a low dose of spironolactone. Now, it says they're 25 milligrams, but I'll be honest, most of the time I would start people on 12.5, which is half a tablet, to see how they tolerate it. And quite often that works extremely well. Or you could start them on an alpha blocker, which is basically doxazosin that we use for hypertension, or you may start a beta blocker. And there would be beta blockers kind of fell out of favor, but there would be times when a beta blocker would probably be the most appropriate drug, especially if they were somebody young who was planning to have children. If you still couldn't control their blood pressure and other problems were occurring, at this point you would be considering seeking specialist advice. Next slide, please. So just quickly running through some of these drugs and how they work. Apologies to people who are very familiar with all of this. So angiotensin converting enzyme inhibitors, or ACE inhibitors as everybody calls them, easy to spot because they end in pril, P-R-I-L. So you may have all sorts at the beginning, but if it ends in pril, that's what it is. And they prevent the conversion of something called angiotensin 1 into angiotensin 2, and they vasodilate, so they open up the arteries, the blood flows more freely, and they increase potassium retention. Now, they do have a well-known side effect, which is a dry cough, and that's because in the process of the angiotensin 1 blocking the production of angiotensin 2, they cause a buildup of bradykinin, which stimulates the respiratory center, and that's why you get the dry cough. And it usually happens at night. The other possible side effect is angioedema. You can get that around the lips, around the eyes. You can get penile angioedema, and it is potentially lethal. So if anybody complains of swelling, the ACE inhibitor should be stopped. They are contraindicated in renal artery stenosis, but that is pretty rare. I don't know that I've actually ever come across somebody with renal artery stenosis, but I'm sure somebody who's watching has. Next slide, please. And the angio2 receptor antagonists, or ARBs, again easy to spot, they all end in sartan. They work in a slightly different way to the ACE inhibitors. They don't cause the buildup of bradykinin, so you don't get the cough. But if you change somebody from an ACE to an ARB, it may take a few weeks before the cough side effect goes away. So warn them it's not going to be overnight. There is some evidence that they may be more cardioprotective. There is some suggestion that they may be more effective in Black Afro-Caribbean people, but that evidence is not strong enough to not start somebody Black Afro-Caribbean on an ACE inhibitor, and some specialist cardiologists still prefer ACE inhibitors to ARBs. At one time we used them together, and we used them quite a lot together here in the Whittington, especially on our nephrology patients, because they were very well tolerated. But studies that investigated long-term outcomes showed that that was poor. You might have got better blood pressure, but actually mortality increased. So we do not give ACE and ARB together unless we really have no alternative. They do have side effects, but it's quite low. Irbesartan can cause muscle pain. Valsartan has been known to give people strange dreams, and olmesartan actually does sometimes cause a cough. Next slide, please. Calcium channel blockers actually covers quite a large group of medications, so I've just gave a quick run through of some of the main ones. So diltiazem is used pretty frequently. We use it a lot here at the Whittington. It's quite popular. It may depress cardiac function, so it's contraindicated in patients with heart failure. Shouldn't really give it with a beta blocker because they both slow down your heart rate, so you could run the risk of heart block. And the other thing we do recommend is that you use the trade name, not the proprietary name. And this was something that was instilled into us when I did my independent prescribing training. The reason being that the different types have different doses, and it's not so easy to swap between or to increase doses if you've got different, if you don't know which particular diltiazem formulation the person is being prescribed. I think that may change in the future as things come off patent, but at the moment, some of the things like Tildium and Dadizem XL tend to be the ones that are 300 milligrams, and as far as I know, there isn't a non-proprietary formulation for that dose, but I may be wrong. Next, dihydropyridines. So nifedipine, it's not used so much, can cause headaches, and I've had a few people who've complained of headaches, but the advantage of nifedipine is it can be used in pregnancy, and it doesn't have the antiarrhythmic activity. It's also used in the non-slow release form sometimes when people come into emergency department with very high blood pressures, but generally speaking you should only give the long-acting formula, and formulation again it is safest to use the trade name so you know which one you're giving. Amlodipine is very, very, very commonly prescribed. 5 milligrams tends to be pretty well tolerated. 10 milligrams will often give people leg edema to the point where they can't get their shoes on. Years ago, we did a drug study where we're comparing amlodipine with valsartan. It was double blind, so we didn't officially know what the patient was being given, but I can tell you we knew exactly what this person was being given because their legs swelled up like balloons, and you didn't have to be Einstein to work out they were being prescribed amlodipine. The other problem is there is some evidence it increases proteinuria, so the nephrology team are not always that keen on amlodipine, but some studies have looked at amlodipine, said, well, the increase in proteinuria is actually not a major problem and it doesn't have an adverse effect on kidney function. So some nephrologists will use amlodipine and some will not, or they'll immediately change the patient from amlodipine to slow-release diltiazem. But that's the same in a lot of areas that have certain favourites. But it is a very effective antihypertensive and it is recommended by NICE. Next slide. So the thiazide type diuretic, as I said, is indapamide. You can use indapamide slow release 1.5 or the non-slow release is 2.5. It is very effective in lowering blood pressure, but you do have to watch out for the sodium levels. There is no evidence to support giving higher than 1.5 or 2.5 milligrams. You're just going to increase the problem with electrolytes, and it can cause erectile dysfunction, but then so does high blood pressure. So it's a question of which is the worst. The thing I forgot to say about the ACE inhibitors and ARBs was that they increase potassium levels, and therefore when a patient is prescribed an ACE inhibitor or an ARB, you should already have a baseline of their sodium level, their potassium level and their creatinine And within a week of prescribing it, you should be getting a repeat blood test to check sodium hasn't dropped, potassium hasn't gone up, and the creatinine hasn't risen significantly, because that would be an indication of renal artery stenosis. Thiazide diuretic, as I said, is benzoflumethiazide. It's not recommended now as a new medication, but if people are on it and they're quite happily controlled with their blood pressure on it, then don't stop it. There is no reason to stop it. Again, not a lot of point to using a higher dose, although some people who are very obese may require 5 milligrams, but again, it can upset the electrolytes. Next slide. Low dose spironolactone. The problem with that is that it can cause gynecomastia, and it can cause high potassium levels. So you do need to keep an eye on the potassium, because it's a potassium sparing diuretic, which is why we only give it in people with a potassium level of less than 4.5. It is now part of the NICE guidelines, but it's not actually licensed for use in hypertension. So the patient should be informed of that before it's prescribed. The 12.5 seems to be pretty well tolerated in my experience, and I've used it quite a lot in the last couple of years. And we use it as a treatment in people who have got something called CONS, which is where they've got an abnormally high level of aldosterone, probably caused by a little adenoma in their adrenal glands that may not be suitable for operation. For removal, and then we would give them spironolactone to try and control the blood pressure, and it seems to work quite well. Next slide. So alpha blockers, the doxazosin is the one we tend to use for blood pressure, and again, they're very effective. They don't affect plasma glucose levels as some of the other drugs may do, and they may help lowering lipids. But a word of caution, in the very elderly, they can cause terrible postural hypotension. So whenever I prescribe doxazosin for the first time, I always get people to take it just before they go to bed at night, so that if they feel dizzy, at least they're already lying down. I always start on a low dose, depending on how old the person is, maybe 1, maybe 2 milligrams. And I did have an elderly lady once referred to me for 24-hour blood pressure recording, who was on doxazosin. She arrived in a taxi and we could barely get her out of the car. She had such terrible postural hypotension with it. So be very careful with elderly people. Do give them a very small dose, and that may be sufficient. 1 milligram or 2 milligrams before bed may do the job. It can sometimes give people heart failure. I have seen people who have been put on doxazosin. They've got very edematous legs, and they have developed shortness of breath, and we've had to stop it. And it shouldn't be used ideally with medication given for erectile dysfunction because of possible increased hypotensive effect. Next. And finally, beta blockers. So they reduce the force of cardiac muscle. They may mask symptoms of hypoglycemia, such as tremor and tachycardia. So they do say to be used with caution in diabetic people who are on insulin or sulfonylureas. Again, they are associated with erectile dysfunction, but as I said, so is high blood pressure, so is badly controlled diabetes. They are officially contraindicated. It's amazing how many people have been diagnosed with asthma on beta blockers quite happily. So I'm not quite sure what the answer is there. And the advantage is they can be used in pregnancy. They're not effective, or not as effective, in people with low renin levels. So they may not be as effective in black people who often have low renin levels. Next, this is the biggie, and I think Joe is going to talk about this in some detail now, but as we all know, don't swallow the tablet, it's not going to work. And it's amazing how many people were coming to say, that blood pressure tablet you gave me isn't working. And I say, well, how often are you taking it? Oh, well, I'm not taking it. Well, that's probably why it's not working, because if you don't swallow it, it doesn't work. it is a major problem. It is so many pills are wasted, so many prescriptions are wasted. I know you're all familiar with this, but it is something we've got to get to the bottom of, and people will cash their prescription quite happily and just collect cupboards full of these tablets. So trying to wheedle out the information is quite difficult. Asking about side effects, I often, patients who have got on water tablets, and I have a lot on frusemide, which makes you pee a lot. I say to them, so how do you cope with the frusemide when you come into clinic in the morning? Did you take it this morning? And they say, oh, no, I don't take it if I'm going out. So roughly how often in a week would you say you don't take it? Because I can understand that. Ooh, maybe 3 or 4 times. Okay, right. So what do? Do you take it when you get home? Oh, no, I just miss it. So it's kind of wheedling the information out of them, asking them what time of day do they take their tablet. Some people have an incredibly complicated regime where they take a tablet every hour, and it virtually takes them the whole day to take all their tablets. Do they remember their lunchtime tablets? Do they leave them at home, or do they take them to work with them? Do they have them, oh, I take them before I go to bed at night. Well, what time? Well, if I remember, I take them at 8 o'clock at night. So it's really kind of being a bit of a detective. And also, do they know what the tablet is that they're taking and why they're taking it? It's incredible how many people used to tell me they were taking metformin for their blood pressure or simvastatin for their blood pressure. So it's really just being, as I say, being a detective. Anyway, I'm going to hand over to Jo now.
Thanks, Liz. Next slide, please. So exactly as Liz was saying there, compliance and the cost of it is enormous. And with hypertension patients, of course, we have such a, it being such a common long-term condition, we have such a variety of patients, one that might only be on one tablet that's not taking it, or someone else that might be on 16 different tablets in the morning with all of their multiple comorbidities. And again, regardless, of course, if they're not taking them, we're not going to get it. So we need to try to get to the bottom of it. Next slide. So when we look at the barriers to adherence, and it doesn't really matter whether you're using the word concordance or adherence or compliance, it still doesn't guarantee, obviously, that the person is taking them. So when we're looking at it, we're looking at what the possible barriers could be. It could be side effect, could be lifestyle. They could just be going through a period where they're just fed up taking the medicines. Could be financial factors, healthcare beliefs, confidence in the outcome of the treatment. Again, with hypertension, we have so many people that don't have any symptoms. So therefore, every now and then they can have doubt over the effectiveness of the treatment and why should they bother. The nature of the treatment, and again, the quality of the communication with the healthcare professional, and the extent to which the patient feels like their problems are understood, and as well, and how we relay then as well the need for the drug and that they understand it as well. Next slide, please. So when we're trying to give support to improve drug adherence, we're looking at patient education. What treatment, what are the treatments available for hypertension, for example? And then we're also trying to include the person in the decisions with shared decision making. And a lot of the time then the hope is that because they've agreed to it, that they will then hopefully will be more adherent. Looking at the benefits and effects of the drugs, discussing how the tablet works, as Liz had already mentioned, taking the medicines at night, and perhaps using a long-acting preparation so that if we try to reduce the pill burden, will that also then improve adherence as well? And discussing the likelihood of whether we'll need more than one drug or not. We know that 95% of people with high blood pressure need at least 2 agents. And then other practicalities such as repeat prescriptions, prepayment certificates, using local pharmacies, aid memoirs, whether that's like an app or setting an alarm on your phone to remind you to take them. Some people have dosset boxes, support from the family, or even, some people, in my clinic, I have a lot of people that have mental health problems as well. So a lot of the time the anxiety can be that they're actually over medicating, that sometimes they can't remember whether they've taken their tablets or not, and they'll take them again. So again, just a simple pill box there sometimes actually just gives the reassurance that they have taken it and they have remembered to take it. Next slide, please. And just to say that when we're talking about prepayment certificates, people with high blood pressure, they don't automatically get free prescriptions. And again, the cost of a prescription, it's like £9.15 per item. We know, again, like most people are on a minimum of 2. So it may just be that, you know, particularly this year with such a flux in our in people's financial fortunes, that it may just be that directing somebody to tell them about prepayment certificate may be just the very fix that they need to help them just afford the medicines at present. Next slide, please. And then this is just showing my community clinic. I also can test, so I get a lot of referrals for people that are on multiple blood pressure agents, and so what I'll do is I can also test to double check actually whether it is actually detected in their urine, and I think it's a very handy tool for me, because it allows me then to open up and sort of challenge that actually, you know, they're not taking it, we're not controlled. What can we do? Do we just need to start all over again and then try to come up with you know, shared decision making or a contract as to how we can move forward to help everybody involved, help the GP, so we're just not wasting taxpayers' money and time, and come up with a solution that hopefully will fit the patient. And if anybody does want to refer, at the slide at the end, I'll give you our email address. It's rfcomplexhypertension@nhs.mail. You can also refer via EMIS Web if you're in Camden. Next slide, please. So just quickly running through the non-pharmacological treatments of hypertension, otherwise known as lifestyle changes. I'll go through all of these now. Next slide, please. Exercise, and I suppose our question here is, are you currently achieving the target for the national recommended weekly amount of exercise? And currently, it's 150 minutes of moderate intensity, which is defined as raising the heart rate and breathing and being moderately out of puff. And, you know, there's lots of different ways, like we can walk, run, swim, go to the gym, dog walking, football. Even housework is regarded, if we're doing it vigorously enough, to raise our heart rate and breathing as an activity. Next slide, please. I like to use the Active 10 app just to try and help people, because if it's something that we can do as part of our everyday life, you know, it's an easy win of a lifestyle change to make. And really what it's doing, it's tracking my walking, and it's telling me how many minutes I've walked that are brisk, because that then is adding up in my moderate intensity. So this is just to give you an example of the app, and you know, when it tells you how many minutes you're doing per day, but you can also look over the last week and months. So this is just to show you last week. You can see I did quite a big walk on Saturday. And on Sunday, you can decide whether I lay on the sofa or went out and had another walk, but just forgot my phone. Next slide, please. And when we're talking about salt, of course, we know that it's the sodium in salt that contributes to the high blood pressure, and it is present in all types of salt, even gourmet, including sea salt, flakes, rock salt, crystals, even Himalayan pink salt. They're no better than table salt. And it's just to say that this is one of the lifestyle measures that really there's very strong evidence for it, and even a reduction from 10 grams per day down to 5 grams per day can actually reduce the systolic blood pressure by 5 millimeters of mercury and the diastolic by 2. So we know that the maximum we should be having is 6 grams, which is the equivalent of 1 tablespoon. And of course, there's so much salt that's hidden, and it's hidden in everyday foods such as bread, bacon, even sauces like ketchup and that as well. So we would sort of recommend that people restrict sauces and things like that, like to a tablespoon a day. Someone's just put up a question there about the app mentioned. It's the Active 10 app, it's a free NHS app, and it's just called Active 10, and it's just kind of handy. I've got a slide showing it at the end. And also the thing about salt as well, we'll see larger decreases in blood pressure seen in elderly people that reduce their salt, and also Afro-Caribbean people, because they're more sensitive to salt as well. So therefore, again, it'll have a greater effect when it comes to it as a lifestyle measure. Next slide, please. So just some salt tips, and really it's just about, don't add salt to the table. It's one of those habits that I think people got into where they automatically would add it to cooking or if they're about to eat. So just try to break that habit. And then also we make taste buds in our tongue every 30 days. So a lot of the time what will happen is that we'll start to reduce our salt intake, and then as we get and develop new taste buds, actually we find if we went back to eating the amount of salt we were eating 30 days ago, we would actually find it too salty. So it's one of those things that actually, as a change, it's a small amount of change to make to actually have quite a lasting effect. So that's kind of why I just wanted to point that out. And of course, we're also trying to cut down on manufactured and processed foods as well. A lot of people I see in clinic, they actually don't know how to cook. And so they're eating an awful lot of processed or microwave meals. So sometimes I'll also use, it's like a little credit card which talks about the food labels. And I just, helping people identify then when they're going out to cook, so that they can identify like low salt and healthier options. So I'll use that as well. Next slide, please. Just to mention about alcohol, and what we do know with alcohol and how it's related to high blood pressure is that, so say if you were having 4 pints of beer a day, and that's like moderate high blood pressure effect, that even you're reducing that can significantly help your blood pressure. So reducing the intake reverses any increase in the blood pressure that is associated with alcohol, and that the blood pressure stays low with those who continue to abstain and reduce that amount. Again, binge drinking has been associated with an increased risk of stroke. So it's just to sort of point out that the units we should be adhering to, all of us, is 14 units a week spread over the week. And if you can possibly have 1 or 2 a day free of alcohol, that would be good. Next slide, please. Just to point out caffeine, and when we were talking there about how to measure the blood pressure at home in that flyer I mentioned, that you shouldn't really have a caffeinated beverage 30 minutes before you measure your blood pressure, because it will give a high reading. So again, it may be that there's some people out there that actually drink an awful lot of tea or coffee. I know I'm certainly guilty of tea. So it's just to be aware that actually it could be another thing that people could reduce a little bit. And green tea as well, just to sort of say it actually has the same amount of caffeine as black tea. So some people might be swapping, not realizing that. And other things like dark chocolate or chocolate coated coffee beans as well are high in caffeine. Next slide, please. And just wanted to point out, the big thing obviously is weight management, particularly this year, and what we're learning about COVID, and what a close relationship between hypertension and being overweight or obese is. And again, obesity is also linked to high rates of obstructive sleep apnea, which also causes a rise in blood pressure as well. So it just could even be that, you might be seeing somebody in clinic and they're just quite tired or find they're falling asleep, and it just could be one of those things that they have high blood pressure too that's not controlled. So just double check, are they snoring? Perhaps you could just do a quick stop bang questionnaire on them as well, because it'll then identify if they're at high risk, and then they can be referred for sleep studies as well. And I know now the sleep studies that are happening, they'll send people. They're doing them at home. They don't need to be coming into secondary care necessarily for them. And then also just to sort of say that the weight management programs, I know certainly in Camden and Islington have just been restarted again with virtual, and then face-to-face is going to restart when lockdown finishes again. And we have exercise on referral. We have the weight management services for adult, and then the rebalance program as well. So they're all there, and they're like 12-week programs which people can join classes and get a reduced membership as well at the gym. Next slide, please. And it's just kind of, when we're trying to look at what the evidence and what's the benefit here. So like a rule of thumb that we would use would be for every kilo that you lose, or which would be about 2 pounds, it would equate to about a 1 millimeter of mercury reduction in blood pressure. Now, some people are going to be a bit disheartened by that, but actually, when you think about it, even like a 5 kilogram reduction is going to be like by 5 millimeters. I certainly have somebody in my clinic who lost over 2 stone of her own volition. She didn't want to do any of the exercise programs, and she literally just started eating better, started walking to work, and lost all that. And we're now reducing, and we've stopped blood pressure tablets. So, and it just goes to show that this multiple approach of weight management, increasing the physical exercise and reducing salt and alcohol intake, that it's not about doing one thing in isolation, but it's actually about doing a number of things. And then we also change that so that it's not, necessarily a diet. It's a change for the better. And it then also then has to be just a good change of habit. If you go to the next slide, please. So it was just to sort of show the NHS apps. I'm not sure where the first, there's one called Easy Meals, which I don't know, the graphic's not coming up for me, so I presume it isn't there. It is. It's just helping people, for example, who are not very, they're not really confident in cooking. And it's just really easy recipes and tells them what they need for their shopping basket as well. We have the Couch to 5K, the Active 10 app. That's the one I was talking to you about, brisk walking, which is just kind of a handy app, and these are all free. And then we've got the drink-free days and smoking as well. And I think for me, even the small changes that we can make such a big difference, because even lowering your blood pressure by just 10 with a combination of all of these lifestyle, well, that reduces your risk of stroke or heart attack by a fifth, which is 20%, which to me is, that's kind of why we're doing both. We're doing pharmacological and we're doing lifestyle measures as well. And I do think they're very important. Next slide, please. So this is just to highlight the document which was created by UCL Partners, which is the COVID-19 recovery plan, which is for the hypertension pathway. And I just want to point this out to you. You all probably should be aware of it, but there's one really, really good slide here, which looking at resources for patients, because of course, so many of us are doing remote consultations now, and we might want to send some information or even videos and even the diary for them to write down their readings. So it's just that's why I kind of wanted to point out this slide to everybody. It's it's very handy, and it'll save you having to sort of find that information that you'll need. It's pretty good. Next slide, please. And that's now for me just to say thank you for your time, thank you for your attention, and if anyone wants any questions, I'll be happy to answer.
Thank you very much. And Liz, if anyone's got a question, please pop them in the chat, put your hand up. I've got one maybe for Liz to take first about the medication. With regards to the cough with an ACE, I've had some patients who seem to have started their cough sometime after starting the ACE. And when we've stopped the ACE, it does seem to have done the trick. But that was, is there much more information about how soon after starting it you would generally expect to see the cough, or is it that it can start sometime later?
Yeah, no, I've had the same issue as well, and with a lot of side effects, they come pretty much in the first month. But with this one, it seems to be a bit accumulative. Yeah, I don't know the actual reasons why, the pharmacological reasons, but I have found that as well.
That's good then. It's not just me.
No, no, it's not just you.
Has anyone got any other questions at all? Please put them in the chat. That was really comprehensive, so I'm sure you've answered lots of things. And thanks for mentioning those apps, because I think the apps are really useful for us to give to patients to encourage them to sort of self-manage with this. So it's just helpful to see those. I think it's so comprehensive. Go on.
No, I was just going to say one thing I didn't say when I was talking about which blood pressure machine to use. I do have some concerns about some of the machines in surgery waiting rooms. And I think if you're using the one where somebody stands and puts their hand in a hole, be cautious. Make sure it's a validated one, because I've had some results fed back to me that have been a little bit weird. The person has shrunk in 2 minutes and then grown again, as well as their blood pressure changing. So it's better to do actual clinic blood pressure if you're going to be titrating their medication. If it's just a general screen or something, fine. But if you're going to be titrating medication, it's better if we actually do it ourselves. It's safer.
I've heard as well that the wrist blood pressure machines are not generally that reliable either.
Yeah, there's one we've got on the website which has been validated and checked, and I can't remember which one it is, but it's BIHS recommended machines. I know that some of the ones on there are a little bit out of date in that you can't buy them, and we are trying to update it all the time. So we are aware of that fact, but there are some that we don't recommend, and we've had discussions with the manufacturers who said, but we've done all the experiments, and they're quite complicated experiments that people studies that people do, where they have to have a certain number of patients in each category, blah blah blah, and the results just aren't accurate enough for us to recommend them. So if they're not recommended, there is a reason.
And just to make everyone aware that NCL LTC is doing a project where on remote consulting and virtual groups with people with poorly controlled blood pressure, and if you sign up to take part in that, you will get supplied with some blood pressure machines that you can give to your patients. So for anyone who's not heard about that's something to maybe think about doing, and getting an allocation of some blood pressure monitors you can use for patients who are unable to afford them for themselves. Okay, thank you, Joe. Thank you, Liz. That's been really helpful and really useful. We will be sending the slides out, and also with the recording, we do find that a lot of people do watch the recording because they're too busy at the time to watch it. So this is going to reach a lot of people, so thanks very much for giving us your time today. It's funny when you're not in a room that you can't sort of applaud or whatever, but I say thank you on behalf of everybody here today. Thank you very much.
Right.
Thank you, and thanks everyone for joining us. Really appreciate it. I know you're on your lunches as well, so thanks.
Hope it was useful.
You're getting lots and lots of thanks comments in the chat.
Yes.
That's great.
Okay. Thank you. Bye, guys.
Thank you.
All right. Take care. Thanks for your time. Bye-bye. Thanks for the invite.